Good morning, dear all. I'm going to talk about prophylactic robotic-assisted laparoscopic radical prostatectomy, RARP, for preoperative suspicion of prostate cancer. As far as we are aware, this study is the first to report results of prophylactic RARP for preoperative suspicion of prostate cancer. We obtained Taiwan Safety and Quality Award in 2016. This is our award. I also win Authentic for advancing the clinical evidence of diversity in novel applications by Intuitive Surgical Incorporated. And this is our award. For the introduction, in our understanding that many of these patients were treated with radical prostatectomy prior to having had a biopsy to confirm the presence of prostate cancer. However, over the years, we have been asked several times whether there is a law for any type of immediately in men with high level of concern for their risk of prostate cancer, despite a negative finding on prostate biopsy. At the beginning, let me present three patients. First, Mr. Yang, 54 years old. His PSA level was gradually increased from 6.8 to 11.7 nanogram m in past 8 years interval. He received transrectal prostate biopsy for 5 times. The pathological results show benign nodular hyperplasia. He suffered from urosepsis at the second prostate biopsy. Since then, he did not want to undergo biopsy anymore. Moreover, he very afraid of the disease because 5 of his relatives and friends had died of prostate cancer. He insists on a definite treatment as for RARP in 2009. After 3 years waiting, I performed the number 366 case of RARP for Mr. Yang. This is the first case of prophylactic RARP for a patient with suspicion of prostate cancer. He and his wife stand by my right side. He is very happy. He is satisfied with the urination and sexual function. Also, his wife is happy. Second case, Mr. Sui. First, he visited my clinic because have nodular hyperplasia was diagnosed at another hospital for 10 years ago. However, his PSA was moderate increase from 10 to 114 nanogram m in 10 years period. I performed digital rectal examination and revealed firm bilateral lobe of prostate. Then ordered MRI study immediately and showed highly suspicious prostate cancer with extracapsular extension. This picture shows prominent anterior prostate lesion with PI-RACE score 5, the incidence of malignant prostate cancer about 95%. He received prophylactic RARP with final pathology proof adenocarcinoma Gleason score 4 plus 3 equals 7, 5% with Gleason score 5. Pathology T3 stage with tumor volume occupied 30% of specimen with focal positive surgical margin at brain neck and apex. The third patient is a medical doctor. Prostate cancer is expected by himself from his condition. He received upfront prophylactic RARP without any prostate biopsy. Pathology revealed early localized prostate cancer. His PSA velocity more than 0.75 nanogram ml per year. MRI showed prostate lesion in right lobe. PI-RACE score is 4. Before we answer the question, is its indication of IRP for suspicious prostate cancer patient in an experienced surgeon, we need to answer 5 questions. First, is it absolutely safe preoperative? Any complications? How about pathology postoperative? The tumor is small? Third, what are the pathology characteristic of a subset of the prostate cancer? 4. How about patient satisfactory evidence after RARP? 5. Can we predict prostate cancer from preoperative data? Is any data can help for preoperative predict? Every case, a thoughtful decision process about the surgery. Number 1, the institutional review board approved. Number 2, the majority of patients had a negative biopsy. Third, all patients were followed for a minimum of 6 months before surgery. Number 4, follow-up in the period prior to surgery, including repeat biopsy, MRI studies, and repeat PSA testing. 5. Patients and their family members were invited to a group education course for prostate cancer management. Number 6, all patients and relevant family members were fully aware of the possibility that patient might well be found to have no prostate cancer in pathology specimen post-surgery. Number 7, all enrolled patients provide signed informed consent. Materials and methods. From December 2005 to April 2017, RARP case by single surgeon total is 1,400. During the February 2012 to July 2015, total 55 cases RARP with bilateral neurovascular bundle preserving for preoperative suspicious prostate cancer patient. patients were stratified by pathology report from RARP specimens. Group 1, prostate cancer, 22 cases, 40%. Group 2, abnormal, including PIN, prostate intraepithelial neoplasm, and ASAP, atypical small acinar perforation. Number 18, 32.7%. Group 3, benign, including nodular hyperplasia or inflammation. Number 15, total 27.3%. Let's talk about the result. Before RARP, clinical diagnosis with biopsy, 1 case ASAP, 5 case PIN, and 36 case nodular hyperplasia. 13 cases without any prostate biopsy. After RARP proved 40% of adenocarcinoma, 32.7% of ASAP or PIN, and benign prostate in 27.3% only. Preoperative clinical characteristics for these patients with mean age 64.1 years and high mean PSA level 16 nanogram m². Moderate size of the prostate, mean volume nearly 60 grams. The extent of PSA velocity more than 0.75 nanogram m² per year is higher in prostate cancer group than another 2 groups. It has statistically significant difference. The extent of PIRAISE score 405 in MRI was higher in prostate cancer group than other 2 groups. It has not statistically significant difference. If we classify the prostate cancer ASAP and PIN as a group and compare with benign group, the extent of PIRAISE score 405 of MRI was higher in cancer and abnormal group than benign group. It has significant difference. Operative parameter and the complication rate of RARP are shown in Table 3. Mean blood loss was 91 m². No anyone need transfusion. 2 Clavia 1 complications were noted, including transient ileus and intraoperative brain injury with repair. The final pathology of prostate cancer in 22 patients, tumor volume ranged from 0.1 to 12 m² with a mean of 3 m². The tumor volume less than 1 m² was found in 8 patients. 2 patients less than 0.5 m². The pathology stage T2A, 2B, 2C, 3A, 3B were recorded as 6, 7, 2, 6, 1. The positive surgical margin rate was 19%, and angiolymphatic invasion was 4.5%. Comparison of preoperative and postoperative urinary function as shown in Table 5. Significant increase voided urine amount, maximal and mean uroflow rate after RARP. Post-voided residual urine, symptom score, and quality of life measure score were significantly reduced. The cleanliness rate was 100%. The mean time of return to cleanliness at day 11 after removal of Foley cyst. Table 6 displayed assessment of preoperative predictive parameters for prostate cancer. Adjusted odds ratio of prostate velocity was 5.97 for prostate cancer group 1 versus benign histology group 3, indicating a significant difference. The crude odds ratio of MRI pyrase score for cancer group 1 versus benign histology group 3 was 3.6 without statistically significant difference. As far as we are aware, this study is the first to report results of prophylactic RARP for preoperative suspicion of prostate cancer with mean PSA 16 nanogram and mean. The final pathology of 55 patients revealed that 40% of suspicion cases had prostate cancer, and at least 91 has clinical significant cancer, more than 0.5 mm. This is an extended indication of RARP from diagnosis of prostate cancer to only suspicion of prostate cancer. All patients had satisfactory outcomes after RARP. For some discussion, the TRUS trust-guided prostate needle biopsy is fundamental for prostate cancer diagnosis. However, 30-day hospital readmission rate after biopsy was 4.1%. The majority, 72% of which was due to infection. The overall mortality rate was 0.09%. This subset of patients with suspicious prostate cancer may undergo first repeat biopsy, may have complications, second, simple prostatectomy, may miss cancer, third, transurethral resection of prostate cancer, the TURP. Dr. Pockney reported that 67 patients underwent robotic simple prostatectomy and 15% was diagnosed with prostate cancer as final pathology, while 30% has complications including 9% severe grade 3 complications. A national population-based study in Taiwan reported that 9,539 patients has undergone TURP with in-hospital mortality rate from 1.16% to 2.37% according to surgeon experience. When prostate cancer its diagnosis after TURP, radical prostatectomy may still be needed later. In high-volume urological surgical practice, complication rate of RARP were reduced to 3%. In our experience, the complication rate reduced to 4% after 600 cases with no mortality. Data from present study show that PSA velocity more than 0.75 nanogram per year is a good predictor of prostate cancer. Dr. Low group presented a large prostate cancer screen study concluded that PSA velocity is useful for prostate cancer detection, with mean PSA velocity 0.6 to 0.7 nanogram ml per year in patients with prostate cancer. They also reported that PSA velocity was more than 0.4 nanogram ml per year twice in 40% of prostate cancer cases. Another study showed that a PSA velocity threshold of 0.75 nanogram per ml an year predicted which men with high-grade PIN would ultimately be diagnosed with prostate cancer. MRI is an excellent tool for detection suspicion lesion. The tumor instead of targeted multiparametric MRI ultrasound image fusion guided repeat biopsy was 65% and 94% in those with 3, 4, and 5 pylori scores, respectively. Dr. Sanami noted that higher level of suspicion on MRI were significantly associated with prostate cancer detection, with an area under the curve of 0.7044 greater than PSA and PSA density. Our data, 70.6% of the prostate cancer group had a pylori score 4 or 5. It is not a preoperative predictor for prostate cancer, which may be due to limited case number. Our cohort of 55 patients had a precursor lesion ASAP or PIN in 6 patients. Brucey group performed immediately open radical prostatectomy in 25 out of 71 patients with ASAP, and all 25 cases confirmed the lesion pathologically as adenocarcinoma. Later, prostate adenocarcinoma was diagnosed in 9 out of 23 patients, 39.1% at repeat biopsy. This also suggested that open radical prostatectomy was the treatment of choice for young patients with ASAP. Woodridge reported using open radical prostatectomy for high-grade PIN in one patient whose father had died of metastatic prostate cancer. high-grade PIN is the most likely precursor of prostate cancer, and adenocarcinoma was identified in 35% of repeat biopsy from patients with PIN. Prostate cancer precursors provide a rationale for prophylactic radical prostatectomy. In patients with no biopsy, the rationale and benefit of RARP need to be justified. All patients in this series had urination symptoms, moderate enlargement prostate, mean volume 60 grams, and high PSA level, mean 16 nanogram m. In addition, 24% of our patients has experienced acute urinary retention. In patient has family history and PSA velocity more than 0.75 and MRI pyruvate score 5, the possibility of prostate cancer is high. In 2015, Andrews, Keller, and Boon-Koo reported 2 cases of radical prostatectomy without prostate biopsy in pyruvate score 5 lesions on 3T MP MRI. He concluded that a high pre-testing probability of prostate cancer, rising and elevation, PSA malignant nodule on DRE and a corresponding pyruvate score 5 lesion on MP-MRI in may be appropriate to proceed to a radical prostatectomy without a prostate biopsy. These 2 cases shown in the slide malignant nodule on DRE, digital rectal examination, and a corresponding pyruvate score 5 lesion on 3T MP-MRI prostate. On Medscape Medical News, reported Professor Roger Kirby, a very experienced urologist, had performed more than 2,000 radical prostatectomies. He did a radical prostatectomy with BRCA2 gene mutation without biopsy and proved prostate cancer at final pathology. BRCA2 mutation has an 8.6-fold increased risk of developing prostate cancer. Prostate cancer in men with BRCA2 mutation is more aggressive and more likely to be fatal. All patients in this study underwent prophylactic RARP based on their willingness to undergo the procedure due to suspicion of prostate cancer, including abnormal PSA, PSA velocity, DRE, MRI, and severe urinary tract symptoms. Importantly, prostate cancer was final diagnosis in 40% patients, including only 2 patients with clinical insignificant cancer, less than 0.5 mm. The pathology stage in T3 and T4 were 27% and 4.5%. The positive surgical margin rate was 18.2% and 4.5% in those with angiolymphatic invasion. The Gleason score 7 or 8 were found in 40%, suggesting further follow-up was needed in another patient with final pathology report of benign or SAP after prophylactic RARP. There was no need to worry about developing prostate cancer. So we back to Q&A for prophylactic RARP. Is it absolutely safe preoperatively? Yes, almost safe. How about pathological postoperative? 40% cancer, 32.7% PIN or SAP. What pathologic characteristics of a subset of prostate cancer? Pathology stage T2 6 case, T2B 7, T2C 2, T3A 6, T3B 1. How about patient satisfactory evidence after RARP? Answer: excellent continence and significantly improved urinary function. Can we predict prostate cancer from preoperative data? Yes. PSA velocity and MRI have some help. In conclusion, we suggest that prophylactic RARP performed by an experienced surgeon is a viable option for patients with suspicion of prostate cancer. Moreover, the present series of RARP was performed by a single experienced surgeon who did not have any surgical bias or maintained excellent outcome. Prophylactic RARP, in our experience, is able to cure prostate disease, including malignancy, precursor lesion, and benign, and also to improve urinary symptoms and quality of life simultaneously. Since our publication, Prophylactic Robotic-assisted Laparoscopic radical prostatectomy (RARP) for preoperative suspicion prostate cancer, our paper was delivered on several renowned websites such as Euro Today, MD Link, the new prostate cancer info link, and ResearchGate. From February 2012 to April 2017, I performed 127 cases of prophylactic robotic radical prostatectomy, and the pathology revealed prostate cancer in 46.5%, ASAP or PIN in 30.7%, benign only 22.8%. Moreover, at 12 months follow-up after prophylactic RARP for sexual function at 60 preoperative potence patients, we used the International Index of Erectile Function Scale preoperative and postoperatively. Postoperative potence means an erection sufficient for intercourse was achieved 88.3%, with or without PDE5 inhibitors. The golden rule on Bible, Matthew chapter 7, verse 12. So whatever you wish that others would do to you, do also to them. We treated patients as our family, our friend. Thank you for your attention.